Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. On behalf of the Saudi Neurology Interest Club, I would like to warmly welcome you all to today's sessions on approach to sudden visual loss. My name is Fahd Tahim, the founder of the club, along with Dr. Lin Al-Khaifan, the head of the PR committee. It brings us a great joy to see you all there, sharing in our passion of neurology and learning together. It is also my honor to introduce our distinguished speaker, Dr. Ahmad ibn Alameer, a neuro-ophthalmology and anterior segment consultant at King Abdullah bin Abdulaziz University Hospital, Princess Noura University. We are truly grateful for his time and sharing his expertise. Before we begin, I kindly ask everyone to please keep your microphone muted during the session. If you have any questions, feel free to send them in the chat box, and we will be happy to address them at the end of the lecture. Wishing you all an insightful and enriching session. Dr. Ahmed, the mic is yours. Thank you.
Thank you very much for your kind invitation. It's my pleasure to be here with you this afternoon, and we hope by the end of this session that you get an idea about how to approach an acute visual loss. So I come from an ophthalmology background, it's going to be like a different than a neurology background, but you will have a different approach. Okay, I usually like to have an interactive session, so I might ask you a few questions during this session. You can just unmute and answer, or you can just type your answer in the chat. So I usually prefer, whenever you approach any case, I start with a differential diagnosis. Keep your differential in your mind. So if you have a differential in your mind, you'll be able to ask the questions. But if you don't have differential, you cannot ask just haphazard questions. So ask yourself, if you have an acute visual loss, is it painful or painless? And ask the patient this question: you have pain or not? And the differential diagnosis is different. It's painful or painless. And some of the differential can be painless or painful, such as optic neuritis. But it's commonly coming with pain with eye movement, but sometimes can come with painless visual loss. So whenever you approach a case of visual loss, think about the eye from the cornea, lens, retina, optic nerve, and the brain in the visual pathway. So if it is painful, think about a cornea condition like keratitis, eye drops, uveitis, inflammation of the eye, endophthalmitis, which is infection inside the eye, acute glaucoma, or optic neuritis if all examination is not suggestive of an ocular condition. If it is painless, think about vitreous condition like vitreous hemorrhage, retinal disease like retinal artery occlusion, choroidal neovascular membrane, retinal detachment, optic neuropathy. So I write optic neuritis in both painless and painful. Ischemic optic neuropathy, toxic, like methanol toxicity, which can come with acute visual loss. Hereditary conditions like Leber's hereditary optic neuropathy can come with acute painless visual loss. And always think about chiasmal or retrochiasmal pathologies leading to acute visual field loss. So we're not talking about the visual acuity. We have to think about it broadly into the visual acuity and the visual field as well. So if you have a differential in your mind, you can ask the question: is it a unilateral or bilateral? It is bilateral. Think about bilateral eye condition or bilateral optic neuritis, for example, or chiasmal or a retrochiasmal condition if it is involving the visual field. Is there a pain or not? If the patient is saying, I have vision loss, is it in the center or it is in the visual field? And when did it start? And for how long? And is it getting worse or it's stable? Are there any associated symptoms? Are there any eye pain or pain with eye movement, which is a characteristic of optic neuritis? Was there any other neurological symptoms like facial numbness, diplopia? If the patient is more than 50, ask about giant cell arteritis symptoms? Was there any transient visual loss before the permanent visual loss, which might indicate a GCA? In any history, you have to ask about the past medical history. Was there a history of cancer? Think about metastasis or any other condition, or like an autoimmune condition, like paraneoplastic, toxic medication. Can anyone name any toxic medication that can cause visual loss? One of the examples are ethambutol, which is used for tuberculosis. Vascular risk factors like diabetes, hypertension. You have to ask all these questions, which might indicate an ischemic optic neuropathy or a retinal condition. Past ocular history, ask about the surgeries, trauma, eye drops. So all these things can help us in pointing toward the diagnosis. Medication use, social history, smoking, alcohol. If the patient is taking like homemade alcohol, think about methanol toxicity. Their diet, medications, travel, sexual history, all are important in the differential diagnosis. Family history, think about hereditary optic neuropathy, systemic review, including the neurological symptoms. So you have to ask all these questions in visual loss. I like to present this slide to all medical students, intern, residents, everyone. So if you want to take an examination, take full examination, including the visual function, like visual acuity, visual field, at least confrontation visual field, and the color vision. Visual acuity alone is not enough. Pupil examination to look for the size of the pupil, the reaction to the light. If it is not reactive to the light, check the reaction to the near, and check for relative apparent pupillary defect. And I will explain it in the next slides. The cranial nerves, including cranial nerves 5 and 7. The ocular motility, the range of motion, strabismus exam, either with Maddox rod, cover and cover. I think this was covered by nicely by Dr. Faisal Khair in his lecture. Saccade and pursuit eye movements. The saccades are the fast eye movement, pursuit are the slow eye movement, and look for nystagmus. And then finally, go for slit lamp examination and the fundus exam. Look for the anterior segment, including the cornea, lens, and look at the retina and the optic nerve. So I would recommend doing a confrontation visual field for every patient you see, especially patients with 20/20 vision with unexplained visual complaint. How to do the confrontation visual field? Just sit 1 meter away from the patient and then put your hand midway between you and the patient. Ask the patient to look at your eye so that you can track and monitor their eye movements, and then test the central vision first, and then test the 4-quadrant using the finger counting methods, as you can see in this picture. Ask them to count how many fingers, 1, 2, or 5, in all 4 quadrants. Don't do the wiggling or the motion moving your eye, yes and no questions, because certain patients with occipital lobe lesion can appreciate the motion, but they cannot count the finger. Is my voice clear? I have a comment here. The voice is not much clear. Okay, clear. Okay. Good. So this is how you perform the confrontation visual field. The color vision is one of the visual function. So let me just explain how it comes. So the photoreceptors are responsible, the photoreceptor responsible for the color vision are the cones here in the center of the macula, which are here concentrated in this area. So any disease affecting this area, the center of the macula, or the temporal part of the optic nerve can cause decreased vision. Macular conditions like macular dystrophy or diseases of the optic nerve affecting the temporal area like optic neuritis, uh, hereditary optic neuropathy, uh, toxic, can cause this decreased color vision out of proportion of the decreased visual acuity. You can test it by the Ishihara plate or the HRR plate. They are available in most ophthalmology clinics. The pupil examination. Before we discuss how to examine the pupil, let's discuss how the light is traveled inside the brain. So the light is absorbed by the photoreceptors and then in the retina, and then will be transferred to the optic nerve, then goes through the chiasm, and then to the pretectal nucleus in the midbrain, and then two signals will go to both sides to the third nerve, especially more specifically in the Eddington-Westphal nucleus. And then the efferent pathway of the pupillary light reflex will start from here to the ciliary ganglion through the third nerve and will cause constriction of both pupils. So if you shine a light here, both pupils should be constricted. Let's suppose that we have an efferent problem in this area. You will have a fixed dilated pupil in this area. When you shine the light here, this pupil will constrict, but this one will remain fixed dilated. You go here, this will constrict, and this one will remain fixed dilated, and this indicates an efferent defect. So an efferent defect will cause a fixed dilated pupil and anisocoria, which is a difference in the size of the pupil. If you want to test the afferent pathway or the optic nerve pathway, if you shine the light here, it will constrict. If you go this side, it will constrict. But if you do the swinging light reflex, if you move back to this eye, it will redilate. In this example, that's a normal pupil, no light. If you shine the light here, both pupil constricts. But if you move the light to the other eye, both will dilate because the afferent is not working. So let's take this example. You can understand the relative afferent pupillary defect. Okay, now before we proceed with the causes of visual loss, any question about the examination or the history or the approach? Please type your questions here, or if you want me to repeat any slide, I can do it. Okay, we'll move now to the causes. We'll start with a painless visual loss. You need to examine the patient thoroughly from the cornea until the retina to look for any pathology causing, explaining the visual loss. So if you're a neurologist, probably you need to ask your ophthalmology colleague to come and examine the patient. I remember one of the patients with multiple sclerosis came to the emergency room with acute visual loss. The patient was not examined by ophthalmology. However, the patient was examined by neurology and or a medicine. I don't remember. I don't recall, but it wasn't here in the kingdom. So he was labeled as an optic neuritis given IV steroid without any improvement. The patient was seen 1 week later with the ophthalmology, and the diagnosis was completely different. It wasn't optic neuritis, it was uveitis. So, anyone can guess what's going on here? Okay. You can see a retinal pathology or a subretinal hemorrhage here, and also intraretinal hemorrhage. And this is called choroidal neovascular membrane. Another example of vitreous pathology, which is called vitreous hemorrhage. Excellent. The one who answered vitreous hemorrhage, yes. Okay. So the first example was CNVM, and the second example was vitreous hemorrhage. What about this one? So that's the normal retina. Excellent. Detachment. Yes, that's a retinal detachment. When we see a break here, that's a break here. We call it rhegmatogenous retinal detachment. In this example, might be subtle, but this area is a bit elevated, and this is detached. And we call this exudative retinal detachment. So when you appreciate the blood vessels here is elevated in this area, probably you will appreciate it more in the 3D image, but this is exudative retinal detachment from an inflammation. Okay, let's start with this case. 70-year-old, let's go to the neurology cases, or 70-year-old male presented with sudden, painless loss of vision. Every information in this, stem is important. 70-year-old, sudden, painless loss of vision. And this is the picture of the retina. What do you see here? Excellent, Lean. Excellent, Ramis. So you see a retinal whitening with a cherry red spot in the center, that cherry red spots, which is a window to the choroid, the normal choroidal vasculature. And this is a retinal whitening indicating a retinal edema. And this is central retinal artery occlusion. This is an emergency. This is a stroke. First, you need to rule out giant cell arteritis by asking the questions of giant cell arteritis like temporal headache, tenderness, jaw claudication, fatigue, fever, night loss, and then you probably need to order the inflammatory markers like the ESR, C-reactive protein, to make sure you're not dealing with a giant cell arteritis. If it is within 4.5 hours, consider the thrombolytic therapy with a TPA because this is a stroke. And unfortunately, there is no effective treatment that has been proven to reverse the vision loss. There might be possible improvement if you do ocular massage within 90 to 20 minutes, or you decrease the intraocular pressure by the paracentesis, medications, anti-glaucoma medication, or hyperventilation into a paper bag to induce respiratory acidosis and subsequently vasodilation. This is a suggested ER protocol from the American Heart Association for the management of acute vision loss. You have a patient in the ER with acute monocular vision loss. Ask the ophthalmology to come and see the patient. And based on their examination, was it retinal detachment, intraocular hemorrhage, optic neuropathy, and the treatment is based on the diagnosis. If they found CRAO, and then is it arthritic from GCA, which is GCA, start with high dose IV steroid and temporal RT biopsy. If it is not GCA or not arthritic, if it is within 4.5 hours, consider TPA. If it is not, and then you have to treat it as stroke by doing stroke workup. So the patient needs to be admitted, and this is a stroke, central retinal artery occlusion equal to stroke. Not just an eye condition, it's a stroke. Clear? If you go by this lecture to understand that CRO equals stroke, it's more than enough for me. Okay? You need to work up the patient for blood sugar, blood pressure, carotid artery by if there is any stenosis in the carotid artery by doing duplex ultrasound, cardiac evaluation by ECG and echo. If the patient is less than 50-year-old, consider inflammatory causes like SLE and infectious workup as well. Now, we finish from the retinal condition that causes painless acute visual loss. Now, let's move to the optic neuropathy. A patient with optic neuropathy, acute optic neuropathy, will present with healthy-looking optic nerve, as in this example, clear margin, pinkish to orange in color, with a small cup. Okay? Or swollen optic nerve. As you can see, the margin is blurred. You can see the cotton wool spots here, sign of ischemia. You can see a hemorrhage. You cannot see the blood vessel. There is obscuration of the blood vessels. So this is optic disc swelling. Later on, if it is chronic, you'll see a pale-looking optic nerve. Whether it was normal at the beginning or swollen, this is the end result. So patients with optic neuropathy will present with decreased visual acuity and or abnormal visual field and or decreased color vision, relative afferent pupillary defect. All patients with optic neuropathy should have a relative afferent pupillary defect, whether it's mild or very obvious, and no other ocular abnormalities that can explain the decreased vision. So if you see a patient with decreased vision, decreased color vision, or abnormal visual field, but the examination was totally normal, cornea, retina, everything was normal, then you have to consider, and there was a relative afferent pupillary defect, it's an optic neuropathy or an optic neuritis. At the beginning, as we mentioned earlier, that the optic nerve can be normal, swollen, or pale, which is a later sign. Let's take another case. 72-year-old presented with sudden, painless visual loss in the right eye 2 days ago. Examine the retina. There is a swollen optic nerve or swelling that is more here in this area, and that's the visual field, or we call it superior altitudinal visual field defect. Any guess what's going on here? Excellent, Fahad. I would call it, before we say this is an ion, I would call it differently. So a patient with more than 50 with optic nerve swelling, relative afferent pupillary defect, and a visual field defect that is most commonly altitudinal, as in our example, or we call it anterior ischemic optic neuropathy. In most of the cases, it is in AION, non-arthritic anterior ischemic optic neuropathy, and in few cases, it could be arthritic, which is secondary to giant cell arthritis. So we call this anterior ischemic optic neuropathy. So we need to rule out GCA, as we mentioned earlier, with CRAO, central retinal artery occlusion, and with ischemic optic neuropathy. How to differentiate? In arthritic or GCA, in the history, some of the patients will complain about jaw claudication, pain in the jaw that increased with chewing, new onset headache, scalp tenderness, myalgia, and constitutional symptoms like fever, fatigue, night sweats. And the age in giant cell arthritis is generally older than the NAION. It's associated in the giant cell arthritis associated with polymyalgia rheumatica, and the vision is usually bad in GCA. And in the ophthalmic examination, we see a cotton wool spot, like in this example, cotton wool spot here, and pallid disc edema, a disc edema that looks pale. It's not like a reddish disc edema. This is a whitish disc edema. So if you see this picture, this is GCA until proven otherwise. Okay? So we call it pallid diffuse optic nerve edema, retinal ischemia, like cotton wool spot. And when you do the ESR and C-reactive protein, it's high. And the normal ESR is age divided by 2, and in female, age divided by 2 plus 10. In the NAION, the patient will not have the GCA symptoms. They have ischemic risk factors like diabetes, hypertension, or they might have obstructive sleep apnea, which is one of the risk factors for NAION. And the vision is usually better than 2100. And if you examine the other eye, you will have a small capless disc in the fellow eye. If you see this patient with diabetes, hypertension, no GCA symptoms, small capless disc in the other eye, it's less likely to be GCA. It's most likely to be in AION. So you see a patient with suspected GCA, you have to do temporary biopsy, and the temporal artery biopsy should be done within 1 to 2 weeks. And if the biopsy is negative, it does not rule out GCA. There might be some sort of a skip lesion. So if it's still highly suspicious, go and do temporal artery biopsy from the other side. But start the steroid. When GCA is suspected, steroid therapy must begin immediately without waiting for the biopsy. And the reason for that is to prevent visual loss in the other eye. So the visual loss in the other eye can reach up to 95% if not treated with steroid. Now, let's move to the most common one, is the non-arthritic anterior ischemic optic neuropathy. Unfortunately, there is no proven therapy, and you need to control the systemic risk factor, diabetes, hypertension, obstructive sleep apnea. If the patient is having snoring, gasping for air at night, you have to do for them sleep study or to refer them for sleep study and to treat the obstructive sleep apnea by CPAP or treat the cause of sleep apnea. The prognosis, the risk of worsening is 30%. You have to counsel the patient about the worsening, 30%. And in 43% of the patients, they might have improvement. The fellow eye can be involved in 15 to 20%. And it's rare to have recurrence in the same eye because we think that the cause is the small crowded disc, the small anomalous disc. When the nerve fibers are really crowded in that area, we think that this could be the possible cause. When there was like ischemia to that area, most of the nerve fiber will be lost, and then we think that the cause, the reason for the ischemia is gone. That's why you have rare occurrence in the same eye. So the nerve, if the fibers will be lost, then the nerve will the crowdiness of the nerve will be less. So this is an example of an arthritic ischemic optic neuropathy. You can see the difference between this eye and the previous eye, the pallid disc edema. Now you can see that the disc edema and hemorrhage here in the right eye. In the left eye, you can see a small anomalous crowded disc with a almost cupless disc. No much cupping in this optic nerve. Now, let's take case 3, a 21 young male with subacute painless drop of vision. The optic nerve looks normal. The eye examination was normal. Probably here is some telangiectatic vessels. We do the visual field, you see bilateral central scotoma. MS, usually this is not the presentation of MS. Usually it comes with, optic neuritis will come with pain with eye movement, usually unilateral. IIH will not cause like a central visual loss at the beginning, acute central visual loss. IIH generally will come with large blind spots bilaterally. If it is chronic untreated, it will cause like a glaucoma, visual field loss, posterior ischemia is likely to be bilateral, but it's one of the differential. But if you see bilateral central scotoma, Dr. Mamdouh, LHON, Fahad, LHON, yes, correct. This could be LHON, Leber's hereditary optic neuropathy. You have to ask the family history. Toxic, yes, it's one of the differential. Johara, excellent. So, excellent, ما شاء الله مركزين. طيب, acute, subacute, bilateral central scotoma. First, rule out ocular condition. Rule out macular condition like TSCR, choroidal neovascular membrane, solar retinopathy by doing OCT examination. OCT will give you a lot of information that cannot be seen by your eye in the examination. So this is a normal OCT, and here an OCT with central serous choroidoretinopathy when you see the fluid under the fovea. And this can cause central visual loss. I have seen cases referred to my clinic, neuro-ophthalmology clinic, and it was just TSCR. And they didn't do the OCT, simple OCT. So it's important to do macular OCT in patients with loss of central vision to rule out subtle macular lesion before working the patients up for optic neuropathy. One of the differential is toxic optic neuropathy like ethambutol or methanol toxicity. So in the history, ask about medication, ask about use of homemade alcohol. Nutritional, usually coming with not acute like chronic progressive decreased central vision. But yes, it's one of the causes of central scotoma or bilateral central scotoma, but it's not usually acute. Hereditary, like Leber's hereditary optic neuropathy, can come with one eye, acute painless loss of vision, and then few weeks later or a few months, the other eye will be affected. Or bilateral optic neuritis. So, in a patient with bilateral central scotoma, make sure the eye is normal, the retina is normal, ask about the family history, ask about methanol use or medications, and then do MRI to make sure it's not like an optic neuritis. The MRI that should be done, I will explain it in the optic neuritis talk or slides. If you see a patient with 20/20 vision and the patient is complaining, this does not mean a normal visual function. You see a patient complaining about some sort of visual changes, you examine the patient, totally normal examination, and check the visual acuity at 20/20. This does not mean normal visual function. We explain it in the first slides. Visual function should be tested by visual acuity, visual field, and color vision. You have to do color vision. You have to do visual field. In this example, the patient have bitemporal hemanopia secondary to pituitary apoplexy, which is hemorrhage in the pituitary adenoma. This is an acute neurosurgical emergency with a 20/20 vision. This patient is having right homonymous hemanopia secondary to left PCA stroke, posterior cerebral artery stroke in this example, and in the other example, optic tract demyelinating lesion secondary to multiple sclerosis. To remind you to examine the full visual function for any patient with a visual complaint, including the visual acuity, visual field, and color vision. So, we're now done with the painless visual loss. Let's move to the painful visual loss. So Dr. Lean asked about is visual damage in AION reversible or not? We mentioned in the prognosis that 40% of patients with non-arthritic ischemic optic neuropathy can have improvement of their vision. Would they improve fully? Less likely, but they can improve. Yes, 40% in 40% of the cases. I usually tell the patient that 1/3 improve, 1/3 remain the same, and 1/3 worsen. Any guess what's going on here? This patient using contact lens and came to the emergency room with painful vision loss. So this is microbial keratitis. So this is an infection in the cornea. You can see this whitish infiltrate in the cornea. Excellent. The one who answered MK, microbial keratitis. Excellent. Okay. What about this one? Patient coming with acute, painful loss of vision. Okay, excellent. Acute hydrops. Okay, this patient is having keratoconus or corneal ectasia coming with whitening of the cornea. We call this acute hydrops. Another patient coming to the emergency room with acute, painful, decreased vision with headache, nausea, and vomiting. The eye is red, the pupil is mid-dilated, and the cornea is hazy. What do you need to check in the emergency room? IUP, excellent, excellent. IUP, we need to make sure the IUP is 45. So this is an acute angle closure glaucoma. This is an obvious case. Patient coming with acute vision loss. The eyelid is red. So this is an orbital cellulitis, orbital condition. It could be orbital cellulitis or orbital inflammation for any cause, autoimmune or infectious. This patient coming to the emergency room with acute, painful, decreased vision. She had cataract surgery 3 days ago. You see the eye, you don't need to do slit lamp examination. You see the eye, you can see this sign. What do you call this sign? So excellent, the one who answered the question. So this is a hypopion, okay, which is white blood cell collection in the anterior chamber. So if the patient is both surgery or trauma a few days ago, think about endophthalmitis or uveitis. But if it is post surgery or post trauma, think about an infection in the eye, which is an emergency, and we call it endophthalmitis. And the treatment of that, tap and inject. Aspirate from the vitreous for culture, and then inject broad spectrum antibiotic. I try to be comprehensive to cover all aspects of acute vision loss, because acute vision loss is not only a neurological cause. It could be most of the time it's an ophthalmic cause. So you need to have an ophthalmologist with you to examine the patient to make sure that this is not an ocular condition. Now, let's move forward. 25-year-old female presented with painful blurred vision in the right eye for 1 day. The pain is worse with eye movement. You call your ophthalmologist, they examine the eye. The vision was 20/40. Color vision was 2 out of 15. There was relative afferent pupillary defect. Otherwise, the eye examination was normal. And the optic nerve here looks normal. There's no abnormality in the optic nerve. What do you think is going on? Neurologist, you can shine here. This is an optic neuritis. What are you going to do? MRI, excellent. Which kind of MRI? It's not just MRI, MRI knee, MRI abdomen. What MRI? Diffusion weighted MRI? No, diffusion weighted MRI, we need it for stroke. But in this case, this is not a stroke. Usually they include diffusion-weighted MRI if you order it. Yes, brain MRI, excellent, with contrast, fat suppression. So we need to do brain MRI, brain and MRI orbit with contrast, including FLAIR images and fat suppression of the orbital MRI. So it's not enough. Space occupying lesion, usually compressive optic neuropathy will come with chronic visual loss, and the optic nerve usually pale on presentation. It's rarely coming with acute visual loss. Some of you answer about the space occupying lesion, but this is an optic neuritis. So that's the brain MRI with contrast. You can see the enhancing short segment of the optic nerve. The other optic nerve looks non-enhancement in the other optic nerve, while in the right optic nerve, you can see a short segment of enhancement in this area. The muscles are normally enhancing, but the optic nerve should not enhance. So we can divide the optic neuritis into typical versus atypical. For typical optic neuritis, the age is usually between 18 to 45. Let me answer some of the questions in the chat before we move forward. So there is a question saying, do we need to wait for the imaging before giving steroid? For patients with acute optic neuritis, it's better to admit the patient, do the imaging, and then if you're sure it's optic neuritis, you can give the steroid. So the imaging can be done the same day or the next day, and then you can start the steroid. So I prefer to do imaging prior to the steroid. So in typical optic neuritis presentation, the age between 18 to 45, coming with subacute monocular loss of vision. It's not usually sudden visual loss like central retinal artery occlusion or ischemic optic neuropathy. It's more of like a subacute over a few days, associated with orbital pain with eye movement in 92% of the cases, and stop worsening within 2 weeks with some improvement, spontaneous improvement within 4 weeks, even without steroid can improve. Typically without disc edema, in 60, we call it retrobulbar optic neuritis, and in pupil examination, you will see a relative afferent pupillary defect. And the color vision, as we mentioned earlier, it's decreased out of proportion of the VA. And in the visual field, you'll see most of the time central or diffuse scotoma, while in ischemic optic neuropathy, it's usually altitudinal visual field defect. In typical optic neuritis, it's usually associated with multiple sclerosis, or it could be a clinically isolated syndrome. What do we need to do in a patient with typical optic neuritis? MRI brain and orbit with contrast, plus minus MRI spine. And the reason for doing MRI is to confirm the diagnosis by looking at the enhancement here, and to look for MRI lesion, the white matter lesion seen in multiple sclerosis, for the risk of multiple sclerosis. So according to the optic neuritis treatment trial, the 15-year risk of multiple sclerosis is 72% if the MRI was positive, and if the MRI was negative for the white matter lesion, the risk of MS is 25%. So this is a T1 imaging with fat suppression and with contrast as well. How do we know this is T1? First, the white matter is brighter than the gray matter. The gray matter is darker, and the vitreous here is dark, the CSF is dark. And this one, the CSF is dark. However, the white matter is darker than the gray matter. So this is a T2. Although the CSF is dark, but this is T2, and this is a special sequence of the T2, we call it. Any answer? Anyone can tell us what is this MRI? So this is T2 because the white matter is darker than the gray matter. However, the CSF in T2 usually white or bright, but in this case, the CSF is dark, and we call this T2 flare. Excellent, Ramiz. So we call this T2 flare. It will show us clearly the Dawson's finger, the periventricular white matter lesions, and we call them Dawson's finger. Those are characteristic of multiple sclerosis. Excellent, Lama. So, according to the optic neuritis treatment trial, so the optic neuritis treatment trial was more than 30 years ago, but this is the result of that ONTT trial. There was no long-term benefit of steroid. However, if you give IV methylprednisone 1 gram for 3 days, followed by oral prednisone 1 milligram per kg per day for 11 days, this will speed up the visual recovery by 1 to 2 weeks compared to no steroid. However, if you give oral prednisone, like lower dose than the 1000 milligram, 1 milligram per kg alone, this will double the risk of recurrence. So in general, if you want to give steroid for a patient with optic neuritis, give high dose of steroid. Multiple sclerosis does not cause only optic neuritis. So if you see a patient in the ER with acute visual loss, with a background of multiple sclerosis, don't think only about optic neuritis. It could be uveitis, either anterior, intermediate, posterior. Just ask your ophthalmologist, come and examine the patient to make sure no ocular pathology. It could be chiasmal, it could be optic tract lesion, as in this example, patients who are coming with right homonymous hemanopia. They can come with diplopia. And Dr. Faisal Deker explained the internuclear ophthalmoplegia in his lecture, which is characterized by limited adduction with abducting nystagmus secondary to medial longitudinal fasciculus lesion. They can come with skew deviation, which is vertical misalignment or double vision, vertical double vision that is not caused by a muscle or nerve palsy, usually indicating a brainstem lesion. They can come with any cranial nerve palsy, third, fourth, sixth cranial nerve palsy. They can come with nystagmus. They can come with certain phenomena like OTOF phenomena, which is worsening of the symptoms with exercise or fever. They can come with Bulfric phenomena, which is altered perception of a moving object. If there is a moving object right to left, they see it like elliptical in shape, so they have altered perception because of the optic neuropathy. They have phosphenes and photism. Those are flashes of light secondary to movement of the affected eye or secondary triggered by noise, smell, taste, or touch. Yes, MS can present with nystagmus. So we talked about typical optic neuritis. What is atypical optic neuritis? We are seeing it now more than before. If the age is less than 18 or more than 45, if the patient is lacking pain, if the vision is very severe or there is a bilateral visual loss, bilateral optic neuritis, if there is rapid response to steroid, you give steroid the second day, the vision improved dramatically. This is atypical. Or if you see a swollen optic nerve, or if you see other findings in the ocular examination, those are atypical optic neuritis. Now you need to think about other conditions. If it is atypical, it's not only MS. You need to do, of course, brain and orbit MRI with contrast plus spine MRI. You need to work the patient up for infectious etiologies like TB. Based on the clinical judgment, history, and examination, you can tailor your investigation. If you suspect infectious, do a TB, syphilis, serology, HIV. If the patient is coming in an endemic area, especially in the eastern areas of the US, think about Lyme disease, antibody-mediated NMO or MOG-associated disease. We will talk about them in the next slides. Inflammatory conditions like SLE, Sjogren, Behçet disease can come with atypical optic neuritis. We need to do ANA and ANCA serology. Think about sarcoidosis if the patient is having some sort of respiratory symptoms. And then consider lumbar puncture with cytology. And if all investigation came back negative, think about hereditary conditions like Leber's hereditary optic neuritis, optic neuropathy. So what is neuromyelitis optica or NMO, Divik disease? It's an autoimmune disease characterized by severe attack of optic neuritis with extensive transverse myelitis. It accounts for almost 50% of the demyelinating disorders in Asia and West India. So it is important to differentiate MS from NMO. Why is that? Because the MS therapy or the multiple sclerosis medication can make the NMO worse. So some physicians are ordering NMO and MOG for any patients with optic neuritis to make sure they are not dealing with NMO or MOG condition, because the treatment of MS can make those conditions worse. It's associated with serum aquaporin for IgG antibody. And when to suspect NMO? If the visual loss is profound, severe visual loss, or lack of improvement by 1 month with steroid, or the optic neuritis is bilateral, it's recurrent, or when you do the orbital MRI, you see extensive enhancement. In the previous example of MS, we saw a short segment of enhancement, but NMO will have more than 50% of the optic nerve enhancing. So those are the core clinical characteristics of NMO. They can come with optic neuritis, acute myelitis, area postremia syndrome. As in, this is the MRI finding in NMO. You can see the enhancement here in the posterior part of the optic nerve at the area of the chiasm. If you see this, suspect NMO. And this is the area postremia syndrome. You can see the enhancement in the dorsal part of the medulla. In area postremia syndrome, patients will present with episodes of unexplained hiccups, nausea, vomiting. The reason for that, because the lesion is located in the medulla, in the floor of the fourth ventricle. In this area, this is the trigger zone for vomiting. It has the chemoreceptor trigger zone for vomiting. So it's affected. Patient will come with hiccups, nausea, vomiting to the ER. They call the GI. They do a lot of investigation. They cannot find explanation. And then you can find the explanation by just doing the MRI, and the patient can be diagnosed with NMO. So hiccups can be symptoms. Okay, they can come with acute brainstem syndrome, symptomatic narcolepsy, symptomatic cerebral syndrome, and the NMO also has some sort of characteristic MRI finding. Now let's move to the MOG-associated disease. So what is MOG? It's an antibody-mediated demyelinating disease of the central nervous system. It's a newly recognized entity. It's distinct from other conditions like MS or NMO. In the past, certain patients are steroid dependent, and we call them prion or chronic relapsing inflammatory optic neuropathy. And with the discovery of MOG, a lot of patients with this condition came back MOG positive. It's recurrent in 50% of the cases, and fortunately, it's a monophasic in 50% of the cases. So around half of the cases, they can come with only one attack of optic neuritis and with no recurrence. And can be bilateral in half of the cases. Typically present with pain with eye movement preceding the visual loss, often few days prior to the visual loss, and then 1 week later, they come with visual loss, optic disc edema in 85% of the cases. So if you see a patient with bilateral optic neuritis that was preceded with pain with eye movement, you see the optic nerve is swollen, think about MOG-associated disease. VA, the vision is usually severe, but fortunately, the recovery is usually good. Steroid. It's better than, the prognosis is better than the enemy. MRI features of MOG, as you can see here, is the bilateral enhancement. It's a long segment of enhancement, usually anterior, while in NMO, usually posterior, and in MOG, usually anterior part of the optic nerve. And you can see the sheath is involved. So if you see involvement of the sheath, it's never MS. So MS never cause perineuritis or optic sheath enhancement. So how to differentiate between MS, NMO, and MOG in the MRI? I'll discuss the orbital MRI, and I can give you an article to read to see all the features, the MRI features of all conditions. So in MS, generally it's unilateral. The enhancement is involving a short segment of the optic nerve, as you can see, less than 50% involvement of the optic nerve, and mainly involving the orbital portion of the optic nerve. While in NMO and MOG, long segment enhancement, more than 50%, and the difference between NMO and MOG is that NMO involving usually the posterior part or the chiasm, while in MOG involving the anterior part of the optic nerve. You can see the sheath here is involved here. If you see sheath involvement, it's likely to be MOG-associated disease. It's mainly anterior perineural enhancement. Is that clear? Like, how would you treat patients with acute optic neuritis? All the same IV methylprednisone. We discussed earlier that according to the optic neuritis treatment trial, whether you give steroid or you don't give steroid, the difference is the recovery time. Now with the discovery of those conditions, NMO, MOG, now the steroid becomes more of like standard of therapy, IV methylprednisone, 1 gram, 3 to 5 days. If there is no improvement of the vision, think about plasma exchange in MOG or NMO. For MOG antibody and NMO, sometimes it's sent outside the country, so the result of the test might take like 2 weeks or 3 weeks to arrive. In this case, we have to consider it in your differential based on the clinical presentation, MRI finding. So think about it, give steroid, send for the antibodies, wait for them. The recovery in MOG is usually good, similar to MS, but in NMO, the prognosis is bad. So for maintenance therapy, a lot of treatment that can be done based on the diagnosis. But remember that disease-modifying therapy in MS should not be given in patients with NMO and MOG. It can cause worsening of the condition. This is a summary slide comparing MOG, NMO, and multiple sclerosis. You can read this article for anyone who is interested to see to read about the difference between multiple sclerosis, NMO, and MOG. And thank you, everyone. Any question? And again, thank you for the invitation. It was a pleasure to be with you this afternoon.
Thank you, Dr. Ahmed, for sharing your expertise on the approach to sudden visual loss. It was an insightful lecture, and we appreciate for all your efforts. Now, for the attendees, the link for attendance and feedback is going to be sent in the chat right now. Please fill it out as it's mandatory to receive your certificate. يعطيك العافية دكتور، شكرا لك.
شكرا، يعطيكم العافية. There is a question for neuro-ophthalmology fellowship. Do you prefer physician from the neurology or ophthalmology background? They're all excellent. So the one who from ophthalmology background, they have different approach than the neurology background, and they are both an excellent choice. Each one has an advantage and disadvantage, so it can be done both ways. شكرا لكم ومع السلامة.